uh, out of the Department of Medical Education. We're very excited to have all of you here today. Before we get started, we'd just like to go over some housekeeping instructions related to Zoom. I will turn it over to our coordinator, Abhishek, just to go over these pieces. Abhishek?
Thank you, Arti. Welcome all to the Fireside Chat. So I just wanted to mention that we have like a large pool of audience here. So I request everyone to please mute yourself so that we wouldn't have any disturbance in the webinar continuing. And you can continue with your question and answers and all your doubts in the Q&A session. Or I'm sorry.
Keep going, Abhishek. You're doing fine.
Okay. So if at all you have any questions before the Q&A session, you can put it in the chat so that, our co-hosts, Aarti and George will take care of your questions and they'll share it with Dr. Shapiro. Thank you all. And I'll hand it over to Aarti back.
Thank you, Abhishek. I'm actually going to turn it over to George to start with some brief introductions.
Thank you, Artie. I appreciate it. So first of all, welcome everybody. I appreciate you joining us here this evening. We're actually honored. So myself, I'm the Associate Director of the Patient Safety Leadership Program here at UIC. And I'm also a faculty member. So I've been working with the program for about 10 years now, and I've greatly enjoyed it. I like to say that quite often I learn as much from my students as I think they learn from me. So tonight we're honored to have Dr. Jo Shapiro with us. She's going to give us a little insight into care for the caregiver programs and whether we really need them. So you'll see some interesting aspects. And with that, my co-host this evening is Artie Raghaven. Artie's got an incredible record herself. Her list of titles is everything from Associate Professor Clinical Pediatrics to Medical Director for the Neonatal Intensive Care Unit. She's also the Director of Quality and Safety Pediatrics. And the program that I'm involved with, she's the Program Director of Patient Safety Leadership Programs in the Department of Medical Education. So with that, I'd like to turn it over to Artie if she has anything else she wants to add at this point, and to introduce Dr. Jo Shapiro.
Thank you, George. We would like to welcome Dr. Shapiro. Dr. Shapiro is an associate professor of otolaryngology and head and neck surgery at Harvard Medical School. I think that is a very simplistic title for all that she has done and contributed to the field of healthcare as a whole. In 2008, Dr. Shapiro founded the Center for Professionalism and Peer Support at the Brigham and Women's Hospital, where she also served as the director for that center over the next 10 years. And during that time, the center actually went on to serve as a national and international resource for other organizations that are attempting to set up peer support programs within their own institutions. In addition to this, Dr. Shapiro personally serves to assist other organizations that are pursuing this journey in providing both support and resources for development of a culture of trust and safety and respect, as well as peer support programs at other organizations. In addition to all of this, she is a well sought after speaker and also an incredibly well published author. And so with this, I'd like to welcome Dr. Shapiro back to UIC. Dr. Shapiro actually has had past interactions and collaborations, and we'd like to give a shout out to Dr. Stephanie Jo from UIC, who Dr. Shapiro has collaborated with previously. So welcome back, Dr. Shapiro.
Oh, it's lovely to be here. Thank you.
George, I will turn it over to you to start with the conversation, and then I'm sure we'll all have pieces that we would like to add.
Sure. Thank you, Artie. Appreciate it. So is Joe okay to prefer Dr. Shapiro?
Joe is just perfect. Thank you for asking, though.
Okay, Joe. Joe, so you've got like an incredible background. And as I was looking into a little bit more, so you've been into this area of peer support programs and providing care for the caregiver. And you've been involved in this since like 2008. Can you give us a little background on how you got an interest and what got you into the field?
Oh, I'd love to. I feel so passionate about this. And the way I got interested was that, so I had various leadership positions at Brigham and Women's and Mass General, including for graduate medical education and being division chief at the Brigham and plus practicing surgery. And it just started to dawn on me that we really had this big gap between what we were all advocating for, which is, great, safe patient care, and how we were treating each other and how the organization was, let's say, treating us, and we're all part of the organization. And, this wasn't peculiar to my hospital. This is part of the culture of medicine. It really struck me that we had appreciated really the humanity of those of us who are actually doing the work, whether it's in training, in clinical care and research, and it really it became obvious to me that there was some needless suffering that was happening, and also that we had a great opportunity to make changes and to take this beautiful kind of healing, compassion, care, and excellence that we all give to patients, and also share that with ourselves and each other. So I pitched starting the Center for Professionalism and Peer Support with the idea that underneath the programs would be this support the well-being of all of us in the organization. And they let me get started. And as you said, I ran the program for a while, but I just really was struck by the opportunity that we had to really care for each other.
Got it. And Joe, did you start from the core up? Because healthcare is sort of unique in the way we interact with patients and work with each other as a team. I think teamwork is critical. So did you focus on healthcare? Were you able to get any insights from any other areas, or what stands out about healthcare that's unique that individuals should know?
George, that's actually an interesting question. One of the pitches I had, because I had to sort of, if you will, sell this to the leadership as something important and that they needed to resource, was I actually used the Southwest Airlines as an example, which was, this was years and years ago, where the head of the airline said, we're going to focus on our employees and they'll then focus on the clients. And I was like, well, what a great idea. And, listen, none of this is original from my point of view. It was looking elsewhere and also seeing how great things can be in healthcare when we do have that support, that teamwork, that kind of, idea that we're in this together, and caring for each other is then going to translate into the great care we give. And as a patient advocate, Meg Gaines, I've worked with, she put it, you can't give what you don't have. The notion that we're supposed to be able to give all this lovely energy and as I say, wisdom and compassion. We can't give that if we ourselves are really hurting. And then at the same time, and this was dawning on me, the literature around burnout started to come out. And so there was started to be proof that what I had noticed as a gap and need was actually quite real and measurable. And so that's been really helpful to have those amazing researchers who've shown us, really just how much of a challenge that we have.
Yeah, and Southwest Airlines has been an incredible success over the year. But as we were speaking, I was reminded of, put your mask on first before you help somebody else, like a child or someone else. You need to take care of yourself before you can help someone else.
I use that too, George. Yeah, that's
okay.
Exactly right.
It
really,
just clicked.
It's so fundamental. Right. And isn't it ironic that we're healers? We're, in healthcare, and we sort of, just really deny our physical, emotional, mental needs. That's just been our culture. And not because we're bad people or the people who came before us were bad people. It really was I don't think we understood the fact that being altruistic and putting everybody else's needs first, sure, in the moment, acutely, that's what our job is, but that it's not sustainable if we're never processing what we've been through, if we're never attending to our own needs. That's just not sustainable. And I don't honestly think that people really, that we, and I'll include myself in this, I don't think we realized it. And now, of course, once we understand it, there's no turning back. We need to pay attention to this.
Got it. Oh, so let me ask you, are there certain times when peer support programs are most helpful, or you hear the term, medical errors, and then the second victim kind of scenario? Anything to that?
I do believe that, when we started the program at the Brigham, and it was a group effort to really get this off the ground, we decided that we're going to start this for acute stressors that are unique to healthcare, like medical errors. It's just, it's not that it's the most common thing that happens to us in our careers, but it because we're human and we make errors, it's going to happen to all of us. And it's, I would say, hands down, the most devastating moment for us, just for all the right reasons. It should be devastating. And so we decided, like, if we were going to do peer support and we're going to really focus on being there for each other, let's at least start with those times that are the most acute and the most troubling. And the other thing, George, is that there's a lot of data, and there has been a lot of data about the emotional fallout after errors. I mean, we know that it's deep and common and can be really long lasting and devastating to people's careers. And ultimately, even though that alone should be motivation to deal with it, it certainly does affect patient care. How are you going to be there for your patient if you are just falling apart? And so we decided we'll start with that as a focus, but absolutely broaden it to other acute stressors and also chronic stressors like COVID, for example. I mean, there's not a COVID day or COVID thing that happens to people. It's just sort of this accumulated kind of chronic stress. So there's nothing about peer support that says it can only be done for errors. And yet I think you have to start there.
I think COVID's totally changed the world, and I think it's opened up things. But in the past, it was always like the provider has to be the strong person, and there was like this negative stigma about you if you said, I need a break or I need help. Did you see that back then? Do you see it now? Where do you see that whole area of, a sign of showing you need help as a sign of weakness? I'm hoping we're past that, but I'm still a little bit worried. So any insights from your perspective?
I think we aren't past it yet, George. It is so much better than it was. I mean, I'm a surgeon. I trained in the day where, if you had a fever, if you were sick, you better still come to work, because people thought, like, we can't, you have to be strong. That's what surgeons are, that's my training. So that's why it's not that other specialties don't have that same culture, but it was very explicit for us. And you were expected. It just did not matter how you were feeling or doing. You needed to show up to work. And it was very much part of the culture. And the way I try to frame this now for people when I talk about peer support is, and you all, you're the experts in patient safety, and I have some expertise in that. I was on the patient safety executive committee at the Brigham, and we integrated peer support into that. But we all know that several things, but when we are treated in a way that is humiliating, and that that undermines our confidence, it has a real negative effect on safety, right? I mean, for all the reasons and yet. And we say now we're all going to we're doing patient safety culture or just culture, right? So a safety culture or just culture. Yeah. But my rhetorical question is, like, did you all get the memo? Did you guys send a memo out to your organization saying we're done with shame and blame? No, right? Because you can't memo your way out of a culture that was entrenched forever before we started seeing that culture of shame and blame is really wrong. And so what I try to to help people understand is we still have to recognize those places and those ways where we're still, we still react in the shame and blame fashion. And that can be even a personal thing. Like I might be judgmental about my colleague before I step back and say, wait, I'm sure, he or she had a really good reason for doing that. And I'm sure they, I'd like to learn and find out more about that versus like, oh my gosh, what were they thinking? So I think we have to pay attention to how the organization treats us, if you will, or acts towards us in terms of, our own needs and shame and blame as an example. And we have to, yes, it's on us to some extent, but, there are a lot of organizational processes that can be very undermining of our health. That's a little more than you asked me, because you asked me more about about the self-care thing. And I want to get back to that and say, we're not there yet we still believe that self-care is selfish. I think we're understanding that it isn't. And not only is it not self-care and self-compassion not selfish, it's part of our professional responsibility. I mean, I need to show up whole is the bottom line. And again, George, I don't have to hardly say it, but I will. It's like, we're not talking about, having 2 hours a day to go to the spa or, to have a, 3-hour debrief. It had this feel to me, every day. I mean, but never, never taking time. That's what's not sustainable.
I think, as you're speaking, it's something we're not taught in the classroom. We don't learn these things. I don't know that you can learn them in a classroom. I think you have to be out there actually getting the experience and doing it and learning. And I think one of the things that comes with experience is wisdom, and hopefully realizing when you need to do and what you need to do when. Given that, COVID has been, I think, a rough time for a lot of us, things we face, things we've gone through. Have you seen any particular lessons, or are there any particular lessons we should learn from what we've gone through with COVID this time?
I do think so. I mean, I think, so when COVID started, I had obviously, been doing peer support for a while, and I got a whole ton of asks for, can you help our hospital start a peer support program now, right? Or can you, can you meet with us, this group, and do a group peer support? Can I lead, what have you? So I have had the honor of being able to do a lot of peer support since the pandemic began. And there's some things that I think it really were glaringly problematic that I think we're starting to see, first of all, the effect, but also to try to counter them. And one was, and I'm going to use this as an example, how we were called, healthcare heroes during the pandemic, which comes from such a lovely place, people wanting to honor the contributions that healthcare providers were giving to patients and to society at large. The trouble with that is heroes are sort of not human, right? I mean, that's sort of, superheroes. That's kind of, I think, the way we conceive of that. And it led people, not just this, but that's an example of it, not just being called healthcare heroes, but this expectation was put on healthcare providers that you will work, double time. You could be deployed to an area that you had no experience in, and because, you were needed, and you just step up to the plate. And we, this, and I'll tell you a story briefly, because it really, really brought this to my, just out to me, is early on in the pandemic, I heard two physicians interviewed. And I remember one of them was an intensive care unit, an ICU attending at a hospital in New York. And the interviewer's asking, what's lots of questions. And then, what's it like for you, And she said something like, I haven't slept in, 3 days, it's just, we're really on it. And I was thinking, like, that's terrible. Like, that's not good not to sleep for 3 days. And why are we holding that up as like, that's the way it should be, when we should be saying, no, that's not healthy. And it is definitely not good for performance. You all in safety know that, right? And there was a lot of that. There was somebody who was broadcasting, I think it was a journalist, broadcasting his illness from his basement or something, where he was like, and he was really, really sick. And I'm like, that's not smart. Can I just, kind of add to this story? I have to tell you that, so I'm not being judgmental about those people, because if I do, I'm going to get myself in trouble, because I will tell you that I got COVID in the beginning of March of last year, really early, probably from traveling to do some peer support training in another state.
Oh.
And I got sick, right? Now I got pretty sick, like I was bedridden for 3 weeks, and I had a bag packed. There were times when my O2 my husband's a pulmonologist, so I had my own little ICU. I was ready to go in the hospital. It was close, and thank goodness I didn't have to, and I recovered, and I'm so grateful. But while I was sick and getting sicker, because that was one of the things that kept happening to people, which we didn't understand, which is like, okay, the first week, all right, and then worse and worse and worse instead of better the week 2, is I was doing peer support and grand rounds from my bed, right?
Oh my.
Literally. And finally, it dawned on me with the help of my family to go, what are you doing? Like, you're supposed to be an expert in this, in well-being, and you're doing exactly what you're telling everyone else not to do. And it was, I had to have in some ways, someone else remind me of that. And also I got sick enough that it was literally not even an option. I just couldn't do it. But seriously, so it just reminded me of how deeply entrenched that culture is. Absolutely. It's the air we breathe. It's everything we've been taught. And we internalize it as like, that's what it means to be a great doctor. And, I was like, oh, people need me. Well, how much hubris to say like they needed me personally. Like, probably people would have been fine if I'd left a couple of weeks and gotten better. So ultimately I did take care of myself, but I just say that to, I want to give myself some self-compassion, but seriously, I was a complete knucklehead. Let's face it.
Well, I'm glad you're well. Joe, we're going to switch gears. I know Artie has some questions she wants to ask you as well, but I also want to remind our viewers that if they have any questions, they should post them in the chat box, and then we'll get to those in just a couple minutes. Artie, do you want to pick it up from here?
Yes, thank you, George. Joe, I think you can attribute that decision to work from your bed to COVID brain fog.
Yeah, thank you. Thank you. I think you're right. I was definitely not myself, I'll say that.
I am curious though, I think you've spoken very eloquently about sort of the journey of caregiver support and well-being over the years. As most people know, the Institute of Medicine came out with the report To Err Is Human. It's about 20 years or more since that report came out. And we know from then that we have about 100,000 preventable medical deaths that happen because of medical errors per year. It's unfortunate to me that that has not been tracked over time. I think there's a few reports that have come out that say that it hasn't improved a whole lot. Let's just call it that. But it's been interesting that there's been some understanding of fatigue and how it impacts patient safety at the resident level. I think that's sort of where we've probably made the most progress as a community, where we have restricted duty hours and things like that. And I think it's for the best, definitely. I just feel like that's only the tip of the iceberg. And in terms of moving our organizations forward, I think the literature as well as the news media has hopefully shed some light on what caregiver fatigue is like over this past year. And I agree. I think there's some competing information out there just within social media and other elements. There's sort of this trade-off between being the superhero with the tired physician that almost made the cover of Time magazine but didn't quite. So I think there is that sort of dichotomy in the culture still that exists. But at an institutional level, if we wanted to start to build a peer support program, where would we start? Because in my mind, it is such a wide concept. I honestly wouldn't know where to build from. So I was wondering if you had any thoughts on sort of what the building blocks would be for that.
Well, I think the good news, Artie, is that it's really easy to build. And when I say easy, what I mean is there's so much interest in doing this kind of work. People are alerted to it now. Most places have a center or office of, or chief wellness officer, something to do with well-being. And this is a program. If it's okay with you, I'd love to just step back and say, like, well, how does peer support as a program fit into other well-being initiatives? And then I could talk about the building blocks. And this is my concept, right? Is I see it as three intersecting circles, which are a Venn diagram, right? And one of them is personal, individual resilience. You should train for a marathon, and you should cook nutritious food, and then don't forget to meditate twice a day, and probably doing some volunteer work, and that yoga class too. And I'm not making fun of these because I do some of them, definitely not the marathon one, but the problem with that is it's absolutely wonderful to think about resilience and to do training. But the problem is that it's really becomes unfair to ask us, and this is a phrase I've been using, to deep breathe through a toxic system, right? And so it can't just be on our shoulders. That's been the whole model for safety, for everything else. It's like, well, it's up to you, be perfect and do all these things, and then things will be fine. And it's like, no, actually, they won't be fine. And it's not just on us. So I think it's a very key component, but should not be the only one. The other circle, the second one, is relational and collegial. And I think if you both would reflect on times when you've been working where you feel that your team or your colleagues are really supportive in service of the work that you're doing, and how great that feels, even if it's stressful, right? The work is demanding, which all of our work in healthcare is. So I think that's a beautiful thing. And I want to acknowledge that we don't, medicine, the way it's practiced now, just certainly compared to when I, started out years ago, is much more isolating. We don't have as much collegiality. Now, you both run a program in training for quality and safety. So that's an example of, like, you create communities of people who can relate to each other and check in with each other. We don't have a lot of that in medicine the way we used to. We just saw each other more. We had more time to do that, and the pace of medicine was different. So I think relational and collegial programs and focus are really key. And then the last one, not least important, but it was originally given short shrift, was what's the organizational responsibility for well-being? What's their role, right? And we're part of it. So, what's our role as organizational leaders to do that? And I think, the data has shown that if you look at well-being efforts, the ones that have the biggest impact on improving well-being are organizationally driven. So I really think, that's very important. And the other thing I want to say is that there are things that the organization has done and does, not intentionally, that undermine our well-being, whether it has to do with our workflow, or how things are resourced. And these things also need to change, right? That's the organization's responsibility. So I think that's an important circle. I made the diagram. So for me, conveniently, peer support, I believe, sits right in the center where those three intersect, right? It's definitely around, helping the individual learn and grow and move through this traumatic period. And that's what peer support is. It's not my telling a peer, this is what you should do. It's like helping them figure out the way forward. It's obviously relational. It's done by a colleague. And so that's really important connection. And then organizationally, it needs to be resourced as a program. Like, it shouldn't just be, let's just, hope that this works and ask everybody to sort of just figure it out. So I think, again, that's how I see peer support fitting in. So in terms of the building blocks, I do believe that this should be a program that's resourced by the organization, whatever that is. And I've worked with different groups. Sometimes it could be within a hospital or a particular healthcare system. Sometimes it can be within a national society for this certain group. It doesn't, there's really no geographic need that it has to be in one way or the other, but it should be resourced where there's someone who's leading it. That's really the main thing. And that there's some administrative support and ways of tracking and those kinds of things. So that's a very important building block. And the other is that believe me, you have to take this with a grain of salt, because I am an educator. So to me, with a hammer nail thing, like, basically everything is an educational opportunity. And I believe for several reasons that we need to train clinicians to be peer supporters, because these are not mental health practitioners that we're training, right? These are like surgeons like I am, right? And I'm not a therapist, not that anybody's ever mistaken me for one. And I don't have the training in behavioral health. And yet, we know from studies, including one that I was involved in, that for example, after errors, what clinicians want is they want to talk to a colleague. They even when we have and we do have great employee assistance program and wonderful mental health practitioners, after some of these occupational traumas is the way I would look at them, people want to talk to someone who's been there, who gets it, who understands in a certain kind of way. And so that, I think, is the fundamentals, and you need to train us to be able to do that, because the way I would normally approach a problem as a clinician, a surgeon, is I'm going to fix your problem, right? You come to me with a problem, you have Zankers, you want me to take your symptoms away. Yes, I'll partner with you. Of course, I want to understand how the disease affects you, but you are asking me to fix it. Peer support, I can't fix my colleague's problem. Now, I teach people how to help, right, in a way that's different from the way you would help a patient, but it's also more than just nodding your head and saying, wow, that sounds terrible. Not that that's a bad thing to do, but I think there are other things we can do. So you need some kind of training, however, what needs, people want to organize that. And then I think it's getting the people in the organization, especially people in safety, risk management, to automatically tell the program director there was an event. So when that program director assigns, Artie, let's say, assigns you as the peer supporter to reach out to the peer, what you can say, and you will say, is on the phone when you connect with them, we reach out to anybody involved in a adverse event, patient aggression, being named in a claim, working on the front lines in COVID, whatever it is, because of course we do. Right. So you normalize it. I'm not reaching out because you're just a loser and we think you're going to fall apart. No, we're reaching out, and we're not waiting till people fall apart. We're saying, like, hey, these things can be stressful. Here it is on a platter. Would you like support? And people can say no, right? But it's not framed as you now have a mental illness because you are having, trouble sleeping after this traumatic event. And by the way, I don't mean to say that having a mental illness is a bad thing. It's just different from sort of the post-traumatic processing that needs to be done than actually, also struggling with a mental illness. That said, some of those people who get peer support are going to need, want, and deserve further support. And so part of the beauty of a formal peer support is that we are trained to destigmatize and facilitate referrals by just saying to anybody, look, hey, it sounds like you're moving along okay, but sometimes this gets under our skin. There's lots of services we have where you can get some more longitudinal support. Is that something you'd like to do? So that's part of how you set it up. You want to make sure you have good resources, because you don't want to just have this is essentially once or twice intervention, but some people will need more. So that's some of the building blocks, and it does require a lot of buy-in and cooperation from people like you, who are going to be hearing about events and having a low threshold for saying, oh yeah, of course we're going to have a peer supporter reach out to you because that's what we do now. So that's a kind of groundwork that needs to be done.
That was so helpful, Joe. I have a bunch of questions related to all of this. So I'll start at the top, and maybe I'll club a few questions together because they might be interwoven in theme and in how you would like to respond to them.
But Artie, can I say something before you go?
Yep.
I just want to thank everybody who's who's attending today, because the thing is, I just want to congratulate you for taking the time out for your own professional development. I think that's really beautiful, because I have a feeling you probably had a busy day, right? and to say, I'm going to do this, I'm going to spend time like learning and understanding, and I think that's really wonderful. So I just wanted to shout out all the participants.
I completely agree. Yes, absolutely. And it's, beyond business hours for many people who are here. And so we really appreciate you taking the time. Thank you. I wanted to ask Joe, from an organizational perspective, um, you mentioned that it's important to get organizational support for resources and for a true culture change to actually happen. I wonder if there are any tools or anything that we can give to our organizational leaders that will help them understand the payoff of having well-supported peer support systems.
Yeah, great question. So, ideally, we would have an RCT that, gave half the hospital, peer support and the other half without, and then compare, the bad things that happened, 10 years down the line to people. But we're not going to do that, right? I mean, maybe some people want to do that. I was not interested when we set up the peer support program at our hospital. I didn't want to do that, although I knew that it would be a lovely study to do. The way that I suggest leaders pitch this to ICT champions who want to lead these programs or interested in them, to pitch it to the leaders who are going to need to resource it, is as follows. Number one is, I think of this like surgery. You've got to look at the risk benefit, right? So you have to look at the risk of doing this, which for them is financial, right? Not a lot, by the way. This is not expensive at all, not at all. But it's the downside. They have lots of priorities, right? And I get that. This is not the only thing on their minds, versus the risk of not doing it. And that's what I've highlighted is we have the data. Do you know, I might say, studies have shown that if you've made it that both burnout and depression are independent predictors of having made a recent major medical error. Did you realize that if you've made an error, you have a higher chance of being burnt out, and if you're burnt out, you have a higher chance of making medical error? Okay, so that most leaders care deeply about patient safety. They do, right? And so you're going to tie this to patient safety because that's what they care about. The other thing is, did you realize that there's a high probability of kind of long-lasting negative consequences for clinicians? A lot of the studies were done on physicians, but not solely, but for physicians in particular, of having been involved in a medical error, including decreased job satisfaction. Right? Lots of things that, of course, those leaders know translate into people leaving, people quitting, people, what have you. And then more intensely, did you know that having made a recent medical error increases for physicians, increases the chance of suicidal ideation? And that medical errors are a risk factor in physician suicide. It's not the only factor, and we all know that, but it's a risk factor. And so, you want to speak the language that the leaders care about. They definitely care about, they actually do care about patient safety. They do care about, burnout and suicide and, depression and how that affects their workforce. Of course they do. And so that, what I frame this is like, there's the risk of not doing this. We already know. We do not have to study it. Now, what's the best way to do it? That's where there's got to be some leeway, which is like, well, we did a study that showed what people, as I was saying before, what physicians want is they want to talk to colleagues, right? As an example. And so you want to build a program. That's what peer support is. Okay, let's build a program where they can get that. There was another study that I was involved in where they looked at, it was a mixed method study where we looked at what were the factors that correlated with physicians who've made a medical error and were willing to be studied, those who became resilient, which is kind of growth post-trauma, versus those who didn't do as well. And one of the factors was talking about it with colleagues. I want to say another factor because it will resonate with you and the people that you have trained. Another factor that positively correlated with resilience after errors was learning about the error and teaching that, giving that learning, sharing that with other colleagues. So what a win-win. It's a win for safety, right? Because now you've learned and you do better things in your system and other people will be alerted. And it also helps us heal. So anyway, my thing is like, look at the data that we have and let's make a program based on what we do understand from the data. Then, we can try to study it. It's very hard to study for lots of reasons, because a lot of what we're looking for as an outcome, like decreased suicide, like, decreased burnout, those are hard to ascribe from a certain program, right? Unless you have a very, unless you have comparative, groups, et cetera. Anyway, so, but what we can say is we're basing this on some science, and, let's try this, and then let's iteratively learn from it and improve it and move along from there.
That sounds, that gives me a lot of hope. I feel like I have something concrete that we can take and say, here's why you should do this. It's a lot harder to convince people, I think, based on what in healthcare we see as softer issues of, emotions and psychology and things like that. And we don't, I think we sort of take mental health for granted, honestly, in healthcare. And so I think having these resources are incredibly helpful. So thank you for sharing that. I have one more question that I wanted to ask you before we sort of address some of the questions that have come through the chat box. It's sort of blowing up on us, so I want to make sure we address those questions. But I did want to ask, there's a lot of tools that are available now to assess caregiver well-being in general. The Maslach burnout inventory is sort of a more common one. Given that in healthcare we have a tendency to lean towards numbers, I think, like you talked about RCTs, and in every way, the first question you get anywhere is, where's the data to support it? And I think that's good. We want to practice evidence-based medicine. But I have a longtime mentor who once told me, there's no evidence. I'm a neonatologist, so this person was telling me, they said, there's no evidence to say that you shouldn't take a baby and throw them out of the 30th floor window, but you probably shouldn't do it. So
exactly. It's the parachute. People said this is the classic parachute thing. We don't need an RCT to know that you should have a parachute on when you jump out of an airplane. Yes.
So
yeah.
I'm curious, in the healthcare quality world, when CLABSI was first identified as a preventable condition, many institutions and organizations and microsystems of units went into sort of this large-scale denial of it being something, or, we're special. And I can speak from the NICU world, we're special, our babies are small, we can't do anything. And, 10 years later, everybody's talking about being 5 years, 6 years CLABSI free. So I'm curious, how important is it to evaluate local well-being in an organization in order to either convince the leaders of its importance or to target potentially limited resources?
Yeah, that's such a fair question. I think, and there's some experts on doing these surveys, and I would defer to them. But what I guess I would say is, I think it's always good to have a sense of what your group is struggling with, and what's working well too, by the way. So I think that's never a bad thing. I'm so for that. What I don't like to see is where people say, well, we can't do this until we've proven that, that our group is suffering, right? And, my answer to that is like, well, what if we did that with all scientific discoveries? Like, well, diabetic patients, just like you said with CLABSI, but, yes, I get that diabetic patients need X, Y, and Z. The study showed that, but we didn't test all the, we haven't done a study at our hospital. So I think you have to be a little bit careful where, look, do we need to know exactly what the burnout rate is in, this department, in this organization? Probably, like, there's so many studies showing very similar burnout and what groups are at risk. Probably not. And yet there's nothing, again, like I said, if it prevented us from doing the work, trying different programs, then I'd say, well, I'm a surgeon, so it's a little bit of like fire, ready, aim, just like do something, we know we have to do something. So if what you're going to do isn't risky, do it, try it and see how it works. So I feel both ways. Like, I think those things are fine, but don't use them as an obstruction to, if we want to do a, X, Y, and Z program, we have to have a RCT to show that it is going to give the benefit, especially when you're measuring the things that you want to measure are hard to measure. And so if you've ever heard Don Berwick talk about measurement in healthcare, and recently, you should listen. He's so eloquent, and he basically has come to believe, and he's like all about measurement science. I mean, all about that we have over relied on measurement in the sense that there are some things that are so difficult to measure, and for that to stop us from doing the right thing is just wrong. So I think it's a balance, right? I think it's a balance.
Thank you, Joe. I want to make sure that we get to the questions in the chat box. So I'm going to stop asking my questions because I could go on for another hour. I know people have better things to do as well for the rest of the evening than listen to me. So I'm going to turn it over to George. George, would you like to go through some of the questions in the chat box?
Sure. And I think if we tried to get through all of them, we'd be on for another 2 hours. So Joe, I'll just put some out there, and let's figure out how to best address this. I don't know how much time you have. I know we're talking about going to the half hour. We'll get a few in. And if you want to stay longer, we could try to cover more. And if not, maybe you can answer the questions. And we do have a LinkedIn page. So I know we're going to put the recording out there eventually out on YouTube and then our page, but maybe we can answer some of them. But let me start, and then Artie, you got access to the list as well. But one of the questions is what advice would you have for starting a peer support program at an institution? So if somebody wanted to get a program started or get something going, what would be the basics that they should look at, and how could they get it going?
Well, again, I'm most familiar with the model that I've helped organizations develop. So, and there are others as well. So I do want to say that. So you could start looking at the different ones and see what appeals to you. That would be the first thing. If someone engages me with that question, I basically would, and actually I've put this out, there's an AMA steps, they have the steps. I talk about what are the building blocks of a program. So, and that's for the public, like you don't have to be an AMA member to get that. So, so basically I want to say that, and also I'm happy to, you just email me if you want, but I don't want to promote myself, like that feels a little yucky. So I would just say, there's stuff out there that I've published that other people published. And then, you just decide what you want to do and get in touch with someone who can help you do program development. They're very simple building blocks, and these things, you could get them up and running, especially with COVID. I've done so much more COVID, during COVID, I've done so much more program development because I'm not traveling to go to each institution and doing 5-hour in-person training sessions, in the Netherlands, and then, in Canada, and then here. And it's like, oh yeah, I can fit in, 3 this week. So I think that's true with, most of us who are doing training, is we could fit in a lot more, but that's what I would recommend. There's a fair amount out there published.
Got it. And I think related to that, a follow-up question is, how do you bring in the different departments, possibly, in a hospital, the organizational development area, or the human resources area, maybe even a psychology area? How would you bring those areas together if you're in a hospital environment?
That's a really important question, and it's slightly, it's a little challenging to answer, mainly because, well, let me just answer it and you'll see why. It depends on who you want to offer peer support for. If you decide you want to do this for all the employees in your hospital, then it's going to be through HR and, EAP and the ones that are providing the stuff that everybody has access to. What we didn't talk about much, and this prompts me to say it, is that there are certain groups, and we know this, and physicians are one of them, and other healthcare, actual clinicians who are, on the healthcare team, who are underserved by these other hospital-based programs. And they're partly underserved because we have actual cultural and structural barriers to accessing that kind of support through those programs. And so you have to be and I work, by the way, I would just say this. So when I was at the Brigham, specifically, I actually did work with EAP, just because we were able to do two different things, but together around peer support. But the one-on-one, frontline clinician to providing peer support for other clinicians, that was really done specifically for clinicians. We didn't do it for all the groups in the hospital, and so I guess what I want to say is that one of the barriers that some people face in trying to start a program is the hospitals say, we already do this. And what you need to say is like, well, is it being accessed by physicians, by nurses, by pharmacists? Like, who's accessing this program? I know you have it, but is it? And I think you will find that because of the cultural and structural barriers, it's very underutilized. And peer support is built to be able to reach out and provide support without waiting for people to suffer, and also to offer it, as I said, in a destigmatized, normalized, collegial way that increases the chance that those who want it will take it, versus like, hey, we have this great program over there, you have to find us and say I'm hurting and get it, the support. So yeah, I think you need to decide like who you're going to offer the support for, and then work with the groups that are relevant to that group, to those groups.
Got it. Okay. And another one, maybe a little bit related, says, how do you see peer support intersecting with the ambulatory space? So if you have those different areas which you touched on, any particular thoughts?
Yeah, no, total particular thoughts. All the fallout, right, from all the emotional fallout from errors, from patient aggression, from being named in a claim. This is nothing. It's hospital based. There's no place that's free from those traumas. Any place where you can be traumatized by just healthcare stuff that happens, that's where, no, so it should be for anybody. It's not just hospital-based clinicians. And I think, interestingly, sometimes the ambulatory arenas are just, people get left out, but they shouldn't, right? And the other, I guess maybe this is implied in the question. Sometimes, for example, with errors, if your threshold is like a major catastrophe, then, and that's the only thing you're going to support for, then you're going to miss some of the errors that happen in the ambulatory setting, where it's slower to evolve that something went wrong, and there's more, there's less clarity of like, well, did this really harm someone? But I want to point you to an article that looked at what was the emotional effect what was the effect of errors on physicians? And they actually studied they looked at whether it was a serious error, sort of moderate one, or a near miss that didn't even reach the patient. And even with near misses, there was physician suffering with job confidence issues and those sorts of things. And so I think we have to be, we can't just say we're just going to support if there was a big catastrophe. No, I mean, in ambulatory, misdiagnoses, all sorts of things, those should be attended to. So there's anywhere that they're healthcare providers, that's where peer support should be.
Got it. Very good point. And I'm just thinking, bringing it home with you, not just in the work environment, bringing it home to family and dealing with everyone. Another one that came up for individuals that are in leadership positions. What can they do to create that burning platform to get everybody else excited about it?
It is so easy to get people excited about it. Like literally, you just do a grand rounds. Like people get, because it speaks to a need that everybody recognizes, but they didn't necessarily give voice to it, or have someone give voice to it. Every clinician I know has suffered in some way from one of these healthcare workplace traumas. Every single one. And everyone says either, I was so grateful that I did have support, or I really wish this was around then. There's just no way. And in fact, I do want to say something. I am not against, having these emotions. Like, we should have deep and intense emotions after we've inadvertently harmed someone, for example. I mean, and the depth of our negative emotions comes from the fact that we care. So it's not a matter of we shouldn't be having these emotions. It's a matter of, can we get some help in processing them, in moving through this trauma? Because it is traumatic. And George, I just wanted to say something. You did say the phrase second victim. I actually don't use that phrase. And the reason is, even though I think it was a great phrase in the beginning, and I'm really grateful to Albert Wu and others who really, they shone a light on this emotional, effect. The reason I don't like it is because the patient advocates I work with don't like our referring to ourselves as victims. And after we've harmed them. And I also feel like victimhood has a very sort of passive lack of agency stance. And I think that we have a lot of agency in this. Like, we are the culture bearers, all of us. We can change the culture by changing how we relate to each other.
I like that perspective. Yeah. No, thank you. Thank you for correcting me. So a new learning for me as well. I've got one from one of our faculty members. Now, this is a bit of a scenario here, but so his question is, are there major differences in caring for the caregiver between the chronic fatigue and weight on caregiver's shoulders versus a severe acute event, such as something like a catastrophic event? For example, since you have Boston ties, the Boston Marathon bombings, are the approaches different in caring for the caregiver, chronic versus acute event?
Yeah, that's a great question. So let me just answer the part, like, for example, about the acute trauma of the Boston Marathon bombing, because that triggered a whole ton of peer support that we gave. Because, as you know, all the Boston hospitals did a beautiful job. It wasn't an error. It was just traumatic, right? People weren't trained to see this much, intense trauma, and it was very upsetting to people on the healthcare team. So we offered tons of peer support, both in groups. And that is partly an answer to this, is when there's been an acute trauma, one of the things that you can do is offer peer support to the group. So, for example, in the Boston Marathon bombing, the orthopedic chief resident asked if I would do a group peer support for all of the orthopedic residents. And he said, we would prefer if it was just you, essentially. And actually, I partnered with someone I work with in EAP, but not the physicians, not the attendings and the faculty, because they really wanted to be able to just be honest, if you will, and about how they were feeling. And they, of course, attendings are evaluating you, and so they felt like they would do better with just our doing it. And I was very grateful that they did set it up that way, because they were very, very honest. And so one of the things about acute trauma is sometimes the whole team is affected, and you can do peer support for a group. And the other thing that's in some ways easier about peer supporting for an acute trauma is the trigger's obvious. It's like, oh my gosh, this happened. Let's reach out now. Let's not wait till the fallout happens. The challenge, it's no less important, but the challenge of offering peer support for chronic stress is, what's the trigger, right? It's like, it's chronic. And so it depends on what that's for. So I would say if you can, when you set up the program, make the reach. So many times, the way you're going to get people to get help when they have a chronic problem is by knowing that there's a safe place to ask for help. So even though I don't think it should be solely a reach-in program, because I think that puts too much of the burden on the individual clinician, if you do have a program, it should be very easy to reach into, and very clear that it's confidential and you're going to be talking to a colleague, and not somebody, basically that, right? So but it's harder because, more challenging, not that it's actually harder to do the peer support. So the actual peer support, whatever the trauma or the stressor is, acute, chronic, is the same. The principles are exactly the same of how you do it. It's just how are you going to get to offer it to those chronic ones? And that just requires some understanding and creativity within an organization. How are you going to do that? Are you going to do a kind of rolling reach out to certain groups that are more at risk? How do you want to do that? And there's lots of creative ways to do that.
Got it. But want to be respectful of the
Yeah.
time. Artie, is there anything else you wanted to add at this point?
I wanted to just ask one last question if we have 1 minute. There's also a theme emerging from some of the questions coming through the chat, which is related to cynicism and skepticism around the success of such peer support programs. There's a question that's specifically related to supporting medical students through the pandemic. Um, so it looks like there's been an effort to really support students and shelter them as they are not just dealing with their own new professional career trajectory, but also with them having to deal with personal crises of family members who are sick. And even though the support systems at least seem to have been established, there's a degree of skepticism and cynicism on the part of the students. And there's other questions in the chat box that suggest that access to the program, because of the challenges and the demands around clinical care for providers, makes it difficult for people to reach out. I was wondering if you could comment on how we could overcome that, if at all.
Well, I think it's completely on point, and it really reinforces what I've experienced and what I understand also from some research that we've done is the barriers are huge. They're huge. They're cultural and they're structural. Students, we all, it's not just students, it's, we all worry about the negative consequences of self-identifying as needing help. And back to, what George and I were speaking about earlier, which is, self-care selfish and vulnerability is weakness, versus like, hey, actually, if you're willing to say you're vulnerable, you must be pretty strong. Like, that's how I see vulnerability. And I don't mean, like I said, like not in the middle of a code, your job is to stand up and take care of people, but again, not forever. And so I think those barriers are real. And I published an article with Tim McDonald, who well, in the New England Journal recently. And we really spent a lot of, it was an opinion piece. It was really focused on the fact that many offered programs, as good as they sound, are not accessed by the people who really need them. And students in particular are very vulnerable, right? In terms of they're being evaluated all the time. And so, if you're going to do a program for students, I believe you've got to do a routine reach out program. A routine reach out, like we are going to, and the way you present it's got to be very, destigmatized. Like, hey, we're checking in on each student. Here's what we're doing. I would like to spend, half hour with you, understanding what's going on in your world now that COVID, we're in the middle of a pandemic. How is this affecting you? Versus saying, I'm checking in to make sure everybody's okay. Are you okay? Because people are going to say, I'm fine. So the way you offer support is absolutely key. And to me, that's part of the training. How do you offer it in a way that destigmatizes it and doesn't have people have to rate how they're doing, but that you say, I'm here to would you like to talk about what's going on with you? That people can be like, oh, okay, I can do that. So I love the question because I think it's quite real and very problematic if we don't change the way we structure the programs.
Got it. Well, Dr. Shapiro, I got to say, this has been very enlightening. I've learned a lot. I think our listeners, I don't think we lost anybody from the start. So we've had a very good session. It's been very informative. Thank you very much for your time and insights. And if anybody wants to follow your work, is there any particular best way they could contact you or follow your work?
You can email me. So it's jshapiro at MGH, the Mass General Hospital, mgh.harvard.edu. And I'm happy to help or direct you in the, whatever way, if you're interested. Again, yeah. I don't want to say.
For our viewers, Abhishek just put your email
okay,
in the
there
chat
you go.
box as well. So grab that.
But as you know, George and Artie, I'm very mission driven. I just feel like, let's do this, even if it doesn't look like my particular model. It's like there's ways to do it. Let's just start moving forward. And we are, like, so many people like you all are interested and care about this. And there's lots of great stuff going on here and in other countries as well.
Great. Dr. Shapiro, thank you very much. I thank all of our viewers or participants for staying engaged. We'll have more information. Just want to let everybody know that we will post a video in a little bit of time. We do have the LinkedIn page, and I think we're trying to plan for our next event on June 10th, but stay tuned for that. So with that, I'm going to say thank you, everyone. Appreciate it. Best wishes. Take care. Bye-bye.
Thank you.
Thank you, everyone.
Stay safe.
Wanted to share our website to our graduate programs in patient safety leadership. I think Abhishek has them in the chat box, so feel free to check out our web pages. We have our latest events posted there. We try to do something almost every other month. At least that's how it's been for the last few months. And we have had some really fantastic speakers. As George mentioned, we will post all the recordings as well. We have an application deadline of July 15th for our graduate programs, so please feel free to share that information with anyone that would be interested. We offer 2 programs. There's a master's program as well as a certificate program in healthcare quality and safety. They're all online. Abhishek has also posted George and my contact information in the chat box, so please feel free to reach out to either or both of us with any questions that you might have. Sharon Lanza is our program coordinator. She couldn't join us today, but her contact information is in the box as well. So thank you with that. And thank you again, Dr. Shapiro, for making the time. And all of you who took out this extra time to not just get this extra knowledge and information, but really to sort of share this journey with all of us. We really appreciate it. Thank you.
Take care.
Thanks.